The IPRO H-Quick presents a conversation on how to start and sustain a successful penicillin allergy program. Interview by Teresa Lebowski, Pharmacist, Quality Improvement, Medication Safety, Lead Nursing Home Quality Improvement Initiative, IPRO, New York. Subject Expert Nicholas P. Torney, Clinical Pharmacist, Infectious Diseases, Munson Medical Center, Traverse City, Michigan.
Hello, my name is Terry Lebowski, and I'm a pharmacist and quality improvement specialist at IPRO. Welcome to a presentation on best practices for a penicillin allergy program. This topic was identified as a need following an assessment completed by 180 hospitals. And of those 180, only 30% reported having a penicillin allergy program. So today, I'll be interviewing Dr. Nicholas Torney from Munson Healthcare, and he is going to highlight a successful best practice in penicillin allergy programs.
Thank you, Terry, for allowing me to join you today. So Munson Medical Center is a 440-bed community teaching hospital, and it's the main hospital of an 8-hospital health system in northern lower Michigan. It's a level 2 trauma center, and we have a 20-bed NICU, and it really cares for a very large rural geographical area in northern Michigan. We have on site, we have 55 pharmacists, about 120 total staff in the pharmacy department. And we have a medical residency program. That's a family practice residency with about 20 residents. We also have a pharmacy residency program with 6 PGY1, postgrad year 1 pharmacy residents, as well as a PGY2 oncology residency program. And previously we had a PGY2 infectious disease residency program for about 6 years. We also have a large infusion clinic that is attached to our main hospital, and they do about between 80 and 100 infusions per day. So quite busy, especially in the summertime. And we have a hospitalist service on site. We have 4 infectious diseases physicians and 1 infectious disease nurse practitioner, which I work closely with on a day-to-day basis. And of note, we don't have a bone marrow transplant or solid organ transplant population in our area. Those go to tertiary care centers. And that really sums up my practice site.
Wonderful. Thank you so much. Now we have a better feel for what your hospital services are and included. All right, so I'll start the interview by asking our first question. How did you get started setting up your penicillin allergy program, and who were your primary contacts to garner support? For example, your C-suite, your pharmacy director, et cetera.
Yeah, so it really stemmed from a conversation that I had with at the time, my residency program director, Mike Tyberg. We noticed that a lot of patients with penicillin allergies are mismanaged. They're provided inappropriate alternative antibiotic therapy. So we had this conversation with our chief infectious diseases physician at the time, Dr. Chris Ledke. So really it was between infectious disease pharmacy and our infectious disease service that really started the conversation rolling. And from there, we took it to our pharmacy leadership, director of pharmacy, and immediate VP of and above pharmacy, and then taking it to our pharmacy and therapeutics committee. Once we developed a protocol and went on from there. We also included our allergy colleagues in our area and within the community, which I think is incredibly important, whether or not you want them to come into the hospital and actually do penicillin allergy skin tests or not. You really should involve them to let them know that your hospital is looking into this, and they really ended up being invaluable in the beginning stages.
Well, those are all great points and a great starting point and guide for the people watching. Now, how long has your program been active, and how many staff are involved in your program?
The program first started in October of 2015, so we are just coming up on the 6-year anniversary here. Yeah. And the main staff that are involved are pharmacists within our infectious disease service line, which would right now be me and a part-time infectious disease pharmacist. We also have 6 pharmacy residents that are trained to do this on an annual basis. And that would be really the direct penicillin allergy skin testing service, which we will get into. So that's really the core members of the skin testing service. Again, it's pharmacist managed and administered. And I do want to note that not all states are able to have pharmacists that are performing the penicillin allergy skin test. So that is another checkbox that you want to make sure as a pharmacy team, check with your board of pharmacy and see if you're able to perform a penicillin allergy skin test in your state.
Oh, an important note, yes, because the states included in our assessment and in the audience vary from, 11, 12, maybe 13 or so different states. So excellent point. Do you have a written protocol or policy, and how often is it updated?
Yes, we do. And this is one of the things that our board of pharmacy came back to us when I asked them, is it okay for pharmacists to perform penicillin allergy skin tests in Michigan? They took some time to deliberate and got back to me and in writing said, yes, it is okay as long as you have a written policy that is P&T approved, that's Pharmacy and Therapeutics Committee, and that document essentially states that a provider is able to order a penicillin allergy skin test, and based on that order, the pharmacist is able to fulfill that order and perform the penicillin allergy skin test, which is an FDA approved process. So our board of pharmacy was okay with that. This outline it's about a 4-page policy, and it's updated every 3 years. And I would be happy to share that with anybody that would be interested.
So does your policy or procedure include recommendations on which patients might benefit from skin testing? What is the process for skin testing, and who does the skin testing in your program?
Yes, of course, all of those things, and I'll go ahead and share my share my slide if that's okay here.
Yes, please.
All right. I guess the first thing to note is the questions that we should be asking the patient and the family member or the family members about the penicillin allergy. So that's really the first and foremost kind of the cornerstone of this service. These questions should be asked every single time. We don't automatically just jump to performing a penicillin allergy skin test. So I'm not going to go through all these questions, but they can certainly be shared with the group. And this can be done. What's really nice is from a workflow standpoint, a lot of times I'll have a pharmacy student or a pharmacy resident go and talk to the patient first and come back with these questions. It's a good experience for them and allows me to kind of delegate some of the work that has to be done as well. So that's sort of first and foremost. Secondly, we have sort of an algorithm, and it can be a little confusing, so bear with me on this, but this is sort of designed to determine which approach would be best when deciding how to delabel a penicillin allergy, if that is appropriate. So at the top bar, a detailed allergy history is, of course, by far and away the most important thing. And then after that, we think about on the left side of the screen here in yellow, does the patient have a reaction to penicillin that occurred over a year ago, and does it include any one of the following? So just a benign rash, which we see most commonly, GI symptoms alone, headaches, and other benign somatic symptoms, or an unknown history. If that's the case, like for instance, my mom told me when I was a kid that I have a penicillin allergy, which is incredibly common. We give those patients a direct oral challenge, which means a 250 milligram dose of amoxicillin, and monitor the patient for an hour. And if that's negative, delabel the patient as, and really that's the gold standard approach. It's very resource light. It doesn't take a lot of resources to do that, and it's very safe. There's literature to support doing this method. On the other side, if someone has a more severe allergy that's listed, so any one of the following, patient-associated penicillin allergy within the last 12 months, or if they have a IgE-mediated reaction, such as anaphylaxis, shortness of breath, angioedema, or for some reason, if the patient or the treating physician is a little wary of a direct oral challenge and they don't have any contraindications to a penicillin allergy skin test, that's when we would perform a penicillin allergy skin test in the inpatient setting, especially if they require active treatment with a preferred beta-lactam therapy. So that's really important as well. We should be really looking at patients that have a need for a penicillin antibiotic. Otherwise, we wouldn't be able to sustain the service and it's skin tests every single patient. Right now, we probably have 60 patients in the hospital with a penicillin allergy.
Yeah.
So, and then just moving on quickly to the penicillin allergy skin test process, I think it's important to understand what this looks like. So a patient's determined to be a candidate, and the scratch test is done first, and that includes 4 reagents. So that would be penicillin G, which is just diluted down, Pre-Pen, which is the brand name for the generic benzyl penicillinoyl polylysine. I got pretty good repetition on that one. And then also sodium chloride for the negative control, and histamine for the positive control. So histamine has to be positive in order to move on to the remaining of the test. Those 4 reagents are placed on the top of the skin, scratched, and we wait for 15 to 20 minutes. If that's negative, then we move on to an intradermal testing with 3 reagents. And so we don't include histamine in that because you wouldn't want to inject histamine intradermally. So yeah, if that is negative, then we would move on to an oral challenge. And then if that's negative, we would delabel the penicillin allergy. So that's sort of the process. It takes about, if you get efficient at this, about 45 minutes for the test itself. And then in all, it could take 2.5 hours for the test. So, and then I'll just go into sort of our results, Terry, if that's okay. All right. So far, we have analyzed 90 patients that have initiated penicillin allergy skin testing. And of those 90, 85 of them were completed. So 3 of them lacked the histamine response. And in those 3, you can't continue with the penicillin allergy skin test. And 2 had an ambiguous scratch test, and we were unable to complete at that point for those patients too. So of the 85 that completed the penicillin allergy skin test, all of those patients had a negative penicillin allergy skin test. So that was 94.4%. And of those that had a negative penicillin allergy skin test, the negative predictive value was 98.8%, which is consistent with the literature that suggests between 97 and 100%. One patient did have a rash within about a day after initiating Zosyn after a negative skin test, and they were promptly switched back to cefepime without any further complications. And then we had, of the 90 patients, I bolded this because this is what I'm probably most proud of with this skin testing service. 76 out of 90, so about 85% of those skin tested patients transitioned to a preferred beta-lactam. So that's really the goal of this, right, Terry? We want to get patients on preferred therapy. We want them off of alternative therapy. And it shows that our stewardship service isn't just performing the skin test, but we're also making recommendations to the providers and making an impact in multiple ways. And I think also what's really unique is that we involved a lot of our pharmacy residents. So about half of these skin tests involved a pharmacy resident, and they're able to go on after graduating from our program and have this unique skill that they can they can implement at their institutions. And then lastly, I just want to mention it's important that you have a process in place to identify if patients get an allergy added back into their allergy record. So 11 out of 85 patients had a negative skin test, had their penicillin allergy relabeled, when analyzed 30 days after. And so I cleaned those up, but something to note that some organizations have sort of a negative penicillin allergy skin test label that they'll sort of make as a filler, if you will, in the allergy field. So it's not an actual substance or a compound or chemical. It's just a filler or a label that we give, that you could give patients that have a negative skin test, so that way the penicillin allergy doesn't get added back in. But those would kind of just be sort of the high points of our results and sort of brief lessons learned.
That's a good point on the relabeling, having it there so it's not missed after all that work is done, and patients, again, getting suboptimal therapy, right, when they shouldn't, right?
Exactly. Yeah,
Yeah,
and then all your work
yeah,
is sort of
yeah. All done.
just
Yeah,
yeah, all
right.
done. Yeah, so super important.
I know that you are the chair for your antimicrobial stewardship program. So is your penicillin allergy program a part of your formal AS program?
Yeah, it certainly is. It's become ingrained in our antimicrobial stewardship program.
Good.
And I mentioned we have 8 hospitals within our health system. There are other smaller critical access facilities that have adopted this penicillin allergy assessment approach, and some have started skin testing, pending their resources. But I mentioned this to say it's really starting to become a system-wide approach to management of penicillin allergies, and something that our hospitalist team has really looked for leadership within our pharmacy department to really help them out, help them help their patients, and it's really been a great addition to our stewardship program.
Very nice. How is the efficacy of your protocol or your program evaluated in terms of antibiotic use, usage
Yeah,
patterns, et cetera?
yeah, of course. And I'll go ahead and reshare my screen here. I have some of our data that I can share again. So this is looking at days of alternative antibiotics avoided. So I took a look at all those 90 patients, and again, 76 of those patients we were able to transition to preferred therapy. Okay, and so what I did is I looked at what the duration of therapy would be in the inpatient and outpatient uh, uh, settings, and I broke that down for each of the different infectious disease states that we identified for our patients, and the total days of antibiotics, of alternative antibiotics avoided, ended up being 1,568. So,
Yeah.
and this is just 90 patients, and so this is just one way to look at this. I know other studies have looked at cost. I think cost is certainly a question as well. We didn't look at cost directly, though certainly you could pull out specific patients, and I could show you for some patients a cost difference. However, I found incredibly difficult to accurately
Mm-hmm.
depict in a retrospective cohort. But
Right.
when we do a penicillin allergy skin testing randomized control trial, that'll be excellent to evaluate.
Yes.
So another thing is we look at antibiotics before and after penicillin allergy skin testing. So this is the date range that we evaluated, and I looked at the antibiotics immediately prior to penicillin allergy skin test, which was in blue on the left. And the y-axis is the number of patients that were on that particular antibiotic. And you can see that vancomycin, King Vanco, is number one here. But Vanco is
Yeah.
alternative. It's an alternative antibiotic. It doesn't work as effectively, and it has lots of safety concerns that we all know about. So we were able to transition those patients to penicillin, piptazo, amsulbactam, and amoxiclav, among other first-line beta-lactams. And you can see sort of a smattering of other antibiotics in here, such as clindamycin and meropenem, even tigecycline, daptomycin, and
Yeah.
aztreonam. So I would say that in
Yeah.
addition to just what you see on the screen here, this has really changed the culture within our hospitalists and intensivist teams that we have really gotten more liberal in prescribing preferred therapy and less scared of using preferred therapy in patients that have penicillin allergies. So that's been sort of a long-lasting effect of this program as well.
That is impressive, and I see like meropenem was totally off the chart post your penicillin skin allergy testing program. We do want to limit that one, right? Yeah.
That's right. That's right.
Does your policy extend to the ED and outpatient clinics? And describe how it looks in those two alternate settings.
Yeah, it's a great question, and there have been papers published looking specifically at a skin testing service in those settings. We do not perform penicillin allergy skin tests in the ED specifically because it's sort of a hectic environment. We're uh, constantly in code triage at this moment. I think it would be difficult to work that into the workflow of the whole team in there, nurses especially. So it's not that we're ruling it out entirely forever, but we kind of look at what the resource allocation is like in the ED and what the throughput is like. And based on that, we're unable to perform skin tests at this time. We wait until they're admitted, and then it's a little more of a controlled environment. But then as far as the outpatient clinics, this is something that we have explored. So I mentioned we have an infusion clinic that is
Yes.
attached to our hospital. They have actually an oncologic surgeon there that is very passionate about penicillin allergies in his patients, and so we get along very well. And so what
Yeah,
he
I
wants
imagine.
is, yeah, he wants a service that for his patients that have penicillin allergies, there's a process where those patients are called, the allergies are vetted, and that detailed allergy history is performed, and we have criteria set similar to the algorithm that I shared, that if a
Yeah.
patient would warrant a penicillin allergy skin test before surgery, then we would set that up. They would come into the infusion clinic, and a pharmacist and nursing team would together perform that penicillin allergy skin test. And then those results would go to the inpatient pharmacy team to select the appropriate pre-op antibiotic therapy. So we know that alternative antibiotics in the surgical pre-op setting will have the propensity to increase the risk for surgical site infections. So using the preferred therapy is that's what this surgeon wants to do for his patients, and we were able to start there and hopefully expand that to other service lines beyond just that one provider.
Wow, and interesting that that provider happens to be in oncology, right? Probably what you
Yeah,
wouldn't expect, right?
yeah, it was a pleasant surprise, that's for sure.
Yeah, yeah. So, Dr. Tourney, how is your electronic health record utilized to advance your program? And with the delabeling?
Yeah, so there's so we use Cerner, and we have an order set for this, so it sort of eliminates the need to hand pick all the different items that go into entering a penicillin allergy skin test. So all I have to do is just type in PAST, and everything just blows in very nicely, and I can just click through and within a matter of a minute or two have all the orders placed in. So from an efficiency standpoint, that certainly helps, and I'm happy to share that with any individuals, Cerner or Epic, and or other, because I think any of those systems could benefit from just seeing an example. But as far as other things that we use our electronic health record for, just updating the allergy history. So trying to, every time you interact with a patient, update that allergy history with as much detail as possible. And if a patient is on Piptazo and they have a penicillin allergy listed, I educate everybody to try to note in there that they have tolerated Piptazo. And so in future, we can look at that history and see if if a patient has tolerated other anti-infectives within that beta-lactam class face up. But those would be the two areas mainly that we use to leverage our electronic health record.
Oh, sounds excellent. Yeah, nice. I like the idea of the order set. That always helps. What recommendations do you have on how a small critical access hospital may be able to start into this penicillin allergy stewardship based on your experience?
So this, again, I go back to this algorithm because this is sort of what I see as step by step for institutions on approaches for delabeling penicillin allergies. And for small critical access hospitals, we know that resources are limited. You may have one pharmacist on at most times a day, maybe two. And this setting happens in our health system. And so what I try to suggest is start with the first approach, which is a detailed allergy history. So you get a patient with a penicillin allergy, start with documenting exactly what happened in your electronic health record and try to put as much detail in there as possible so that in future encounters you're able to quickly identify that. You don't have to go through the depth of an allergy history every single time. That would be number one, and you could even work that into a nursing workflow so that it removes sort of the work from pharmacy. After that, I would suggest looking into direct oral challenges. The majority of patients, if you can't delabel their allergy with an allergy history, you can look into a direct oral challenge because most of those patients meet this criteria, a benign rash or other benign somatic symptoms or an unknown history. So highly recommend looking at that. I would say, in the 50 to 75% range of patients between those two, you'd be able to delabel the allergy. And then beyond that, if you're able to, look into a pharmacist managed and administered penicillin allergy skin test. That is an option. It's just, you just have to look at your resources, and maybe it's not a pharmacist, but maybe it's an NP, maybe it's a nursing driven, maybe you have a provider that's a champion. Looking at where your resources live and who is really passionate about this will help you decide which approach you take for penicillin allergy skin testing.
Very nice. Thank you.
Mhm.
And what recommendations do you have for training staff on this program on penicillin allergy management?
Yes. So penicillin allergy assessment and skin testing certificate program is now available. And this is something that's been live since 2019. So basically it's a continuing education accredited program similar to like a vaccine administration program, and it's intended for any healthcare provider that is involved in antibiotic administration or prescribing or really anything involving antibiotics. The program is 11 hours of home study and enduring material, and there's 10 modules that are performed by folks all over the country that are experts in penicillin allergy skin testing, and it also has a 4-hour live session with an instructor checkoff. So you complete that 11 hours beforehand, and then the 4-hour live session is meant for you to understand exactly how to perform a penicillin allergy skin test, and it goes through all your questions and anything that you would be interested in knowing from that expert instructor that can come on site and perform that. And if you're interested in doing that, you can email the email that I have listed here, PAAST at collegeofpharmacy.southcarolina.edu. And I will note that I don't get any royalties for this, so just wanted to mention that I just am very, very passionate about improving the outcomes of patients with penicillin allergies, and this is really, in my mind, one of the best ways to do that by getting yourself and your colleagues educated. So I do have, I think, yeah, one more slide here just to show sort of what this looks like pre-pandemic and mid-pandemic, if you will. So in 2019, we had a great showing. This was our first skin testing certificate program, so about 20 or so folks showed up for that. And in 2020, some of our students and residents showing off their new skill that they learned.
And I see this. They actually did the skin test on each other as part of that live work.
Yeah, that's right. Yeah, they build friendships that way.
Yes, that is wonderful. Thank you for sharing that with us, and thank you for sharing your expertise with us. Do you have any references you'd like to show the group today?
Yes, of course. So one thing that I'll mention that I haven't brought up yet is this idea of beta lactam cross reactivity, and it's something that we've all learned to different degrees, and I don't know. I wish that we could have a show of hands of all the people that are viewing this, of how many people have actually seen this in clinical practice, seen a patient with a penicillin allergy that was given another beta-lactam and had a true cross-reactivity, I think we can all admit that this is very rare, and it really has a lot to do with the side chain. So this document, these green check marks here, just show that these agents, when cross-referenced from the sort of the XY axis and Y axis, when there's a check mark, it means that there is no cross-reactivity associated with the side chains. And if a patient has a non-severe allergy, you can feel very comfortable recommending that agent. So penicillin and is the drug choice. I feel very comfortable using cefazolin in that setting, whereas these other agents where the X is present with cephalexin and ampicillin, those have unique, actually identical side chains, in which case we would want to avoid those agents if someone had a severe allergy. So that's sort of how this document works, and it's actually just went live at our facility this summer. Before this, we didn't have anything like this. And one of our residents, I just want to
Wow.
give Derek, yeah, one of our residents, Derek Linsky, I just need to give him a shout out for all the work that he put together on this project.
Yeah, that's beautifully done, and it's all just in one easy chart to read. So it's excellent. So thank you, for sharing that.
Yeah, and happy to share that with anyone that's interested in having that.
Wonderful. All right. So I think that comes an end to our interview. And I would like to thank you again, Dr. Torney, for sharing how you built your successful penicillin allergy program, and how you are definitely an allergy steward. Isn't that how we say it now? You're an allergy steward.
That's right. Yeah, there's antibiotic stewards and allergy stewards, and I think they're one and the same. And
Yeah.
thank you so much, Terry, for having me on.
Yes, thank you for your time today.
Join us for more support. How? Contact Teresa Lebowski, Pharmacist, Quality Improvement, Medication Safety, Lead Nursing Home Quality Improvement Initiative. tlebowski@ipro.org. Visit us at qi.ipro.org. Follow us on our social media channels: Facebook, Twitter, LinkedIn, YouTube. This is a product of the collaboration between IPRO, Health-Centric Advisors, Clarent, Kentucky Hospital Association, Q3 Health Innovation Partners, and Superior Health Quality Alliance. Serving as the IPRO Hospital Quality Improvement Contractor for Minnesota, Wisconsin, Michigan, Kentucky, Ohio, Pennsylvania, New Jersey, Maryland, Delaware, New York, Massachusetts, and Maine.